The next topic is composite resin. In 1956, it was R.L. Bowen who developed a polymer based on dimethacrylate chemistry. So this polymer was given name as BIS-GMA or Bowen resin that was made. So BIS-GMA is also known as Bowen resin. In 1956, the Bowen resin was developed. In 1960, traditional or microfilled composite were discovered. In 1970, the microfilled and light initiated composite. In 1980, the posterior composite, and in year 2000, the nano-filled composite were discovered. What is composite? It is a highly cross-linked polymeric material that is reinforced by amorphous silica, glass, and crystalline or organic resin, bonded to matrix by coupling agent. The composite indication, these are the indication they have been used in class 1, class 2, class 3, class 4, class 5 or class 6 cavity. They have been used in core buildups as a sealants and preventive resin restorations, specially used for aesthetic enhancement procedures, used as cements, veneering metal crown or bridges, or the temporary restorations. Contraindication where the isolation is difficult with high wear and tear cases or bruxism cases, patient with high caries index with a poor oral hygiene or areas like subgingival area. Advantages of these fillings, they are conservative, less complex, used universally. There is no corrosion, no health hazard, and cheaper than the porcelain. The disadvantages includes polymerization shrinkage, technique sensitivity, higher coefficient of thermal expansion, increased occlusion wear, low modulus of elasticity, lack of anti-carcinogenic property, staining, and are costly. According to the Skinners, the composite comes under, they can be either traditional composite that are macro filled with size 8 to 12 micrometer, the small particle filled composite with size 1 to 5 micrometer, and the microfilled composite with size 0.04 to 0.4 micrometers. The hybrid composite with size 0.6 to 1 micrometer. According to the NOVs, the composite can be classified according to the particle size and their clinical use. According to the Sturtevant classification, they can be divided on base of filler particle size. They can be megafill, macrofill, midfill, minifill, microfill as well as nanofill. So learn the particle size based on the filler particles. Like minifills, they will have particle size range between 0.1 to 1 micrometer, and nanofill will have particle size between 0.005 to 0.01 micrometer. According to the Craig, they can be divided into class 1, class 2, class 3, class 4 based on the particle size. And type 2 classification, macro size like 10 to 20 micrometer. They can be classified on the method of curing like chemical, UV light, visible or dual cure. Based on inorganic loading, they can be heavy filler material or lightly filler material. Based on consistency, they can be light body, medium body or heavy body. According to the matrix composition, they can be BIS-GMA, UDMA. What are the major components The major components are the resin matrix, coupling agent, and the inorganic filler. Other components are inhibitors, color stabilizers, pigments, activator initiator system, as well as optical modifiers. Resin matrix. A resin material is that forms a continuous phase and it binds with the filler particle. What are the principal monomers that we use? The first is the bis DMA. It is also known as boron resin. And other is UDMA. The dilutant monomers that are used, they form highly cross-linked polymer structures like TEC-DMA, EG-DMA, HEMA. Why we use these dilutants? Since this resin it is very viscous, so in order to improve the clinical handling, it is diluted with the low viscosity monomers to control their viscosity. So these can be bisphenol A dimethacrylate, that is bis-DMA, or ethylene glycol dimethacrylate, EG-DMA, triethylene glycol dimethacrylate, TEG-DMA, or methyl methacrylate, MMA. What are the inorganic fillers? The fillers, they will improve the physical as well as mechanical properties of the organic matrix. What are the common fillers that we use? They are silicon dioxide. So with the addition of the filler, there will be reduction in the coefficient of thermal expansion. It reduces the polymerization shrinkage. It increases the abrasive resistance, decrease the water absorption, increase the tensile and compressive strength, increase in the fracture toughness, provides radiopacity, improves handling properties, and increases the translucency. The main aim is to incorporate high percentage of the fillers. The smaller the size of filler particles, better will be the finish of the restoration. So the filler loading, it is always 50 to 85% by weight, or 30 to 70% by volume. So how these filler particles they are produced? The filler particles they are produced by grinding or milling the quartz or glass to produce particles that range in size from 0.1 to 100 micrometer. So the submicron silica particles, they are referred as microfillers. Classification of fillers. Number 1, if the quartz, because of its hardness, it was difficult to grind to the finer size and was difficult to polish. Second is the silica. So how silica is obtained? It is obtained by precipitation process. The silica can be in the form of pure silica, fused silica, or the colloidal silica. Third are the classes like aluminosilicate or borosilicate that can be used to provide radiopacity. Other fillers that can be used are the tricalcium phosphate and zirconium dioxide. Recently, fluoride fillers has been used like yttrium trifluoride and ytterbium trifluoride. So they will ensure acceptable aesthetics of the composite translucency of the fillers. The translucency of the filler should be similar to as that of tooth structure. The other component is the coupling agent. So the coupling agent function is to bond the filler and the resin matrix. So it transfers the forces from flexible resin matrix to stiffer filler particles. It prevents penetration of water along with the filler resin interface and provides the hydrolytic stability. The coupling agent we use are the organic silane. So the main purpose The main purpose of coupling agent is to bond the filler to the organic resin. So this agent is a molecule with silane group at the one end and methacrylate group at the other end. So we can use organosilanes, titanates, zirconates. Coming to the activator initiator system that can be chemically activated, that consists of two paste. The example of chemically cured composite, the initiator activator here system is benzoyl peroxide and 2% aromatic tertiary amine. Whereas with the ultraviolet light activated, here the initiator activator system is 0.1 benzoyl methyl ether composite. And in case of visible light cured composite, the initiator activator system is 0.06 camphoroquinone and tertiary amine. So remember these for your exam point of view. The initiator activator system. Next component is the inhibitor. So what is the function of inhibitor? So these agents will inhibit the free radical that is generated by polymerization of the monomer. So the example of inhibitor is butylated hydroxyl toluene. Optical modifiers includes pigment like metal oxide, opacifiers including titanium dioxide and aluminum oxide. Now let us discuss the type of composite. They can be traditional, small particle, microfilled or hybrid. The traditional composite or the conventional or the macrofilled composite, they consist of filler, that is the filler here is finely grounded amorphous silica or quartz. The filler size is 8 to 12 micrometer. They are indicated in class 2 and class 4 restorations. What are their disadvantages? They are difficult to polish. They have a surface roughness, staining, shows occlusal wear and shows poor aesthetic. The next are the small particle composite. Here the filler is amorphous silica glass containing heavy metals. The filler size is 0.5 to 3 micrometer. They are indicated in high stress and abrasive prone areas like class 4 cavity. The advantages are they have a good mechanical properties, good smoothness, less polymerizing shrinkage, radiopacity, but they are prone to wear and deterioration. The third are the microfilled composite. The filler is colloidal silica particles with the organic fillers. The filler size is 0.04 to 0.4 micrometer. They are indicated in aesthetic restoration for anterior teeth, for restoring subgingival areas, carious lesion on the smooth surfaces, like in class 5 restorations. So their advantages, they have a best surface finish, excellent wear resistance. The disadvantages are their tensile strength, water absorption and coefficient of thermal expansion is less, fracture resistance, radiolucent and decreased polymerization shrinkage. The hybrid composite, the filler is colloidal silica and ground particles of glass containing heavy metals. The filler loading is 70 to 80%. Now the filler size is 0.4 to 1 micrometer. Indicated in anterior restorations, known stress bearing area in the posterior teeth. So they have a good physical property, improve wear resistance, superior surface morphology. The disadvantages are they have increased surface roughness with time. The nano composites, they are extremely small composite. So their particle size is below the range of wavelength of light and they do not absorb or scatter visible light. Let us discuss the recent advances in composite. The flowable composite, they have a special handling properties as they are fluid as they show fluid injectability.
introduced in year 1996. The filler particle size is similar to the hybrid composite. The filler content is reduced, that results in viscosity. So they will improve the handling characteristic of existing composite. So remember, they have a low filler loading that is responsible for their decreased viscosity, and that is why they can be injected into small preparation. So they are a good choice for pit and fissure restorations. So filler size is 0.6 to 1 micrometer. Filler content is 30 to 35% weight by percentage. So they are indicated in pit and fissure sealant, amalgam margin repair, class 1, 2, 3, 4 and 5 restorations, core build-up, incisional edge repair, enamel defect repair, etc. Packable composite. So these packable composite has been developed to improve the compressive, tensile and edge strength as well as handling of the composite. So due to the high viscosity of this packable composite, they can be pushed into the posterior teeth preparation. So their basis is rigid inorganic metric material. So they have a polymer rigid inorganic matrix material. So the resin and ceramic inorganic fillers, they are added in the silanated network of ceramic fibers. So these fibers, they are composed of alumina and silicon dioxide. So they have improved mechanical properties because of ceramic fibers. They have improved handling properties because of presence of irregular porous fillers, fibrous fillers and resin matrix. The next are the organic modified ceramic. So let us discuss the recent advances in the composite. The first is the ormosers. What are ormosers? They are known as organic modified non-metallic inorganic composite materials. So remember, the organic modified ceramic will have both the organic as well as inorganic matrix. So they will have organic molecules having methacrylate that forms a cross-link matrix. The inorganic molecules that make a three-dimensional network that is formed by inorganic polycondensation. And third are the fillers that are added to this complex. So they are more biocompatible than conventional composite, shows higher bond strength. The polymerization shrinkage, it is least among resin-based filling material. They are highly aesthetic as comparable to the natural teeth. They show high compressive strength. They are indicated in case of for the aesthetic veneers, for orthodontic bonding adhesives and restoration of all type of preparation. Other are the compomers. The compomers name is polyacid modified composite resins. So they have a combined advantage of composite as well as glass ionomer cement. So they consist of two components, that is dimethacrylate monomer with two carboxylic acid groups present. So they are available in single paste. The first compomers that was introduced was direct. So they show a fluoride releasing with improved physical properties. The fluoride release is greater than the composite resin but less than glass ionomer cement. They initially will release high level of fluoride, but after some time the level of fluoride would fall rapidly to low level. Their color matching and optical properties, they are superior than glass ionomer cement. The adhesion to tooth is by micromechanical and required acid etching. The physical properties like strength are as similar as composite. So they are easy to handle, easy to polish and easy to place. So requires no mixing. Bone strength, it is higher than the glass ionomer cement. It has a paste that contains calcium aluminium fluorosilicate glass filler in a dimethacrylate monomer, so that's set by polymerization and then acid base reaction. So they have a higher barrier than composite and lower fluoride release than the conventional glass ionomer cement. These are their indication. They are used as a sealing and filling for occlusal pit and fissures, restoration of deciduous teeth, minimal cavity preparation or tunnel preparation as a core buildup, class 5 repairs, etc. The next are the geomers. So geomers, they are hybrid of word glass ionomer and composite. So remember, they are also known as PRG composite, that is pre-reacted glass ionomer composite. So they have property of both glass ionomer and resin composite. So they are resin based material that contains pre-reacted glass ionomer particles. The particles, they are made up of fluoroaluminosilicate glass that has been reacted with polyalkanoic acid before incorporated into the resin matrix. So geomer, they are very much similar to compomers and composite in that they are light activated and require the use of bonding agent for adhesion to the tooth structure. They have a optimum fluoride release, easy to polish than glass ionomer, excellent aesthetics, better surface finish, and bond chemically to the tooth structure. They are indicated in non-carious cervical lesions, root caries, or deciduous tooth structure. What is the difference between the compomers and geomers? In compomers, the variable amount of polyalkanoic acid is incorporated into the resin matrix and acid does not react with the glass until the water uptake occurs into the restoration. Whereas in geomers, it is the fluoroaluminosilicate glass particles that react with the polyalkanoic acid in water prior to their incorporation into the resin matrix. Next are the smart composite. So the smart composite will release calcium hydroxide and fluoride when pH in restoration is less than 5.5. So it releases the fluoride, hydroxyl and calcium ion if pH falls. The fall in pH is due to the deposition of plaque in the area. So these smart composites works on the technology that alkaline glass fillers will inhibit the bacterial growth and reduce the formation of secondary caries. So the paste will contain barium, aluminium fluoride, and silicate glass fillers. So the fluoride release from the smart composite is higher than the compomers but less than the conventional glass ionomer cement. Remember that for your exam point of view. Ceromers, they are ceramic optimized resins. They are processed as inlay or onlay or used as a short span bridges. So they have a three-dimensional loaded fillers in polymer matrix of which two are fluoride releasing. So they contains barium glass, spheroidal mixed oxide, ytterbium trifluoride, and silicon dioxide in bis GMA. So they are indicated in stress bearing areas class 1, class 2 posterior restoration, class 3, class 4 anterior restorations, class 5 cervical caries, root erosions, etc. The polymerization of composite resin, they can be divided into two categories. One is the self-curing composite, other is light curing composite. In self-curing composite, that consists of paste system that is in form of catalyst and base. So one part will contain organic tertiary amine that will be the accelerator, and the other part will consist of benzoyl peroxide initiator. So both the catalyst and the base, they are mixed in ratio 1:1. So what you see is on mixing there will be polymerization process that will be chemically activated. So various type of other is the light activated composite resin, where we use light that can be visible light or UV light. Various curing lamps that has been used in case of for curing of light cure composite resin are tungsten quartz halogen curing unit, plasma arch curing unit, light emitting diode unit, and argon laser curing unit. The tungsten quartz halogen curing unit, the most conventional and most commonly used curing light for composite resin. So here it is incandescent lamp that uses visible light in wavelength of 410 to 500 nanometer. What we use here is halogen bulbs that have limited lifetime of around 100 hours. So what are the disadvantages of this method? The bulb life is limited, that is 100 hours. Intensity of bulb that decreases with time. It is time consuming process. Other is the plasma arch curing unit. Here we use is the electric field that is used to generate high voltage. So this field will ionize the xenon gas into mixture of ion, electrons and molecules that will release energy in the form of plasma. The disadvantages of this technique, it is expensive and of large size. Third is the argon laser curing unit. Nowadays we use is the argon laser that has a wavelength of 470 nanometer, that is monochromatic in nature. The advantages being are the polymerization, it will be uniform and not affected by distance. There will be greater depth of curing that will be achieved with this light. It may affect adjacent restoration. Chances of damage to pulp can occur due to the rise in the temperature. Last is the light emitting diode unit that has a long life and emit powerful blue light. So this light will fall in the narrower wavelength of 400 to 500 nanometer. So that corresponds to range of camphoroquinone photoinitiator that is found in most of the composite resin. The advantages are it has low power consumption, can be used with batteries, does not require filter, it has a long life. The disadvantages is only suitable for camphoroquinone based composite because it has a limited wavelength spectrum.
The degree of conversion or polymerization of composite. That means the percentage of carbon-carbon double bond that have been converted into single bond to form a polymeric resin. The complete polymerization of composite, it is determined by degree of conversion of monomer into the polymer. What are the factors that will affect the degree of conversion? Curing time, shade of composite. The darker shade polymerize slower when compared to the lighter shade. The distance and the angle between light source and resin. The recommended distance is 1 mm. The intensity of light decreases as the distance is increased. The angle of source should be 90 degree to the resin. If the angle diverges from the 90 degree, then intensity of light would decrease. Temperature, the curing would be less if it is taken out immediately from refrigerator. The composite should be at least kept at room temperature 1 hour before use. Resin thickness is one of the main factors of its curing. It should be ideally 0.5 to 1 mm for optimal polymerization. Oxygen in the air can affect or inhibit the polymerization of resin. The intensity of curing light decreases as the lamp ages. So the optimum wavelength of light should be 400 and 500 nanometer. Coming to the C factor, the C factor was introduced by Professor Carol Davidson. It is it is the ratio of the bonded surface of restoration to the unbonded surface. So the ratio of the bonded surface of restoration to the unbonded surface is the C factor. For class 1 and class 5, its value is 5. For class 2, it is 2. For class 3, it's 1. In class 4.5, and for smooth surface restoration, it's zero point 0.2. So the higher the value of C factor, the greater is the polymerization shrinkage. So you will see that a class 1 cavity, class 1 and class 5 would have highest polymerization shrinkage. So let us discuss the various tooth preparation design. First is the conventional method. The conventional design, it is as similar to that of tooth preparation for the amalgam restoration, except there is less outline extension, and in tooth preparation the walls are made rough. So it is indicated the preparation are located on the root surface, used with the moderate to large class 1 or class 2 restorations. The prepared enamel margin should be 90° or greater. The butt surface, cavo surface margin that is made on the root surface. The tooth surface is roughened, that will increase the bonding. Second is the beveled conventional method. It is indicated when composite restoration is used to replace an existing restoration, exhibiting a conventional tooth preparation. It is more suitable for class 3, class 4 and class 5 restorations. Third is the modified design. It is more conservative in nature since retention is made by micromechanical bonding to the tooth structure. It is done for the initial or small carious lesions, so the preparation will have scooped out appearance. So extent will depend upon the depth of preparation will depend upon the extent and depth of carious lesion. The box only preparation, this design, it is indicated when only proximal surface is faulty, with no lesions present on the occlusal surface. The facial or lingual slot, it is designed for restoration. It is designed for restoring proximal lesion on the posterior teeth. The shade selection. Remember that the shade selection should be done prior to the prolonged drying of the teeth, because the dehydrated tooth become lighter in shade as a result of decrease in translucency. The composite shade is selected by working with clean moist tooth prior to the placement of the rubber dam. Natural light is preferable. What are the effects of acid etching? There will be dissolution of core enamel, increase in the surface area up to 2000 times. There will be a reaching depth of 10 to 20 micrometer. It exposes the proteinaceous organic matrix, removes the smear layer that increase the wettability and surface area.
and removes 10 micrometer of the surface enamel. It also removes the deposit plaque. So three type of etching pattern are there: type 1, type 2, type 3. What is type 1 etching pattern? There is preferential removal of the rod core. In type 2 there is removal of the rod periphery, and in type 3 that is irregular and discriminate pattern. What are the substances that we use for acid etching? Generally we use is the phosphoric acid 37%, citric acid 10%, polyacrylic acid 40%, or malic acid 10%. So bonding, you can use a low viscosity resin that will flow into the etched enamel pores to form resin tag. The bonding agent, it is applied using a micro brush. So it penetrates the irregularity on the enamel and bonds micromechanically by forming resin tags. And on dentine, it penetrates the collagen network and the dentinal tubules. Two categories of technique are commonly used in curing polymers: continuous and discontinuous. The continuous cure refers to the light cure sequence in which light is on continuously. There are four types of continuous curing: uniform continuous cure, step cure, ramp cure, and high energy pulse. The continuous cure, it is conducted with halogen arch and laser lamp. Whereas the discontinuous cure, it is also known as soft cure, that commonly uses a pulse delay. So in the uniform continuous curing, intensity is kept uniform over the time. Whereas in the step curing, the intensity is increased in the sudden step over the time. The ramp curing, in which the intensity continuously increases over time. Whereas in the high energy pulse, the high intensity is kept for shorter exposure time. Now what are the different design of increment placement? Three increment design. One increment is placed at the gingival and occlusal wall, and two oblique increments, they are placed both at the proximal box occlusion, occlusion box. The first increment is thinner than 1 mm. The horizontal layering design, small increments are placed horizontally one above the other, that are starting from gingival wall to the occlusal wall. Oblique layering, the increment is placed obliquely and curing is done from all three sides. U-shaped layering, a U-shaped increment is given. Vertical layering technique, they are in vertical pattern and the curing is done behind the wall. Layering technique, in this the proximal box and the curing layering technique in the proximal box and curing each increment by inserting the fiber optic microtip into the composite. What is tunnel restoration? So it is a conservative approach for class 2 restorations. It is indicated in patients with high aesthetic demands, low caries rate with small proximal caries without involvement of the marginal ridge. So it there is it doesn't involve the involvement of the marginal ridge. So it is contraindicated in the large proximal caries involving the marginal ridge or marginal ridge that are under excess occlusion load. So the advantages are the marginal ridge is preserved, there is reduced micro leakage. The disadvantages, There is poor visibility and lack of caries removal. Marginal ridge may be undermined. Preparation may extend close to pulp than desired. The sandwich technique it was developed by MC Lean, or it is also known as bilayer technique. It is used for large class 3, 4, 5 and class 1 and class 2 restoration. There are two types of technique, one is open and one is closed. In the closed sandwich technique, the GIC is placed over the pulpal floor and axial wall. Then the composite is placed and cured on GIC. Whereas in the open sandwich technique, the GIC is placed on the gingival wall and on that composite is cured till the occlusal level. So the advantage is it has a favorable pulpal response due to biocompatibility of GIC. There is fluoride release that minimize the recurrent caries. There are less composite is required and less polymerization shrinkage is there. Whereas disadvantage is it is time consuming, technique sensitive.